Welcome to the Healthier Pregnancy Presentation Series. I'm here with Dr. Therese Zink from Wright State University, Department of Family Medicine, to discuss the Affordable Care Act covered preventive service of intimate partner violence screening. Thank you for taking the time today to discuss this very important topic. We are going to be talking about the screening process, interventions, counseling, referrals, and what providers need to know when they're screening pre- and perinatal patients around the topic of interpersonal violence. So, first of all, why don't you tell us a little more about your background?
So I'm a family physician, and I've been practicing almost 30 years and have practiced in a variety of settings, so inner city, urban, suburban, and also rural. And intimate partner violence is alive and well in all of those settings. Mm-hmm. And it is, the focus of ACA is on reproductive women, but it's a problem for teens, it's a problem for older women, and so we really need to think about it for all our patients, even men, although most of the studies have been the most focused on reproductive age women. Mm-hmm. Mm-hmm. And I guess the other thing that's important to say, if there's intimate partner violence, we also need to think about child abuse, but that's not the focus of this discussion.
Well, so why do you think that it's, the ACA focuses on pre and postpartum issues? Why is that such a critical area for us to focus on and think about?
So it's a segment of women that we interact with a lot in the healthcare setting, and so there's lots of opportunities to understand what's going on and to interrupt the cycle of violence. So we know that it can be generational, and that if we can intervene in the life of a woman and the life of her children, that we might make a difference for generations to come. So you often repeat what you learn as a child or you see as a child.
So it really gives providers a chance to maybe change the course of a family and change the course of a woman's life.
Right. Mm-hmm. Right. And I think one of the reasons that we ask is part of what we're doing is we're educating to say it's not appropriate to be hurt by somebody that loves you, and that it's stressful to live in a situation where you're always on pins and needles about if you're going to provoke somebody's anger, and that that's not a healthy relationship. And so help people understand that so they can either find a safety or do what they can to create a healthy relationship.
So I think this is a topic where providers think, my goodness, how am I going to ask these questions? How am I going to screen for this? What do I say? What tools are out there? So what guidance do you have to offer about screening?
So there's been many screening tests that have been tested, and those are definitely valuable in certain settings. There's one specifically geared toward pregnancy, the abuse assessment scale, and if you're in a setting where you have a large number of patients moving through, it may be a prenatal clinic, then it may be best to use a computer screen or to use a written screen. The important thing is that you look at it and somebody follows up. And I like to, when I train students and young doctors, I think the important thing is to have a conversation with the patient. I care about what their living situation is. At the same time I'm asking about smoking or how they use alcohol, who do you live with, how do people get along, is it a stressful place, is it not a stressful place, if it's a stressful place, what's that like, because that affects your health. And I think that's the point, that living in an abusive situation affects your health, and we know that it affects the health of your baby as well. Mm-hmm. And so understanding what's going on so that you can help a patient understand what is normal in the sense of healthy, and if it's not that there are other options, that there are people that can help them when they're ready for that.
So you're advocating for providers to be asking these questions along with other health behaviors, smoking or other types of habits, for example.
So it's part of understanding what a person's life is like to help them lead a healthy and productive life. Mm-hmm. So it's one of the handful of things that are really important to ask about, mm-hmm. particularly in the lives of women.
Mm-hmm. So how does a provider know if a screening tool is positive? For example, at what level do you follow up and that woman might need more intervention? How do you figure that out?
Yeah, so sometimes you don't know for sure. Sometimes patient give you clues or cues. Sometimes I'm doing a pelvic exam on somebody and it's particularly uncomfortable for them, and I may say, has someone hurt you before? And that patient may or may not share it with me. And so if I'm not sure, I say, well, some people have been hurt by people that love them. Some people have been forced to have sex that they didn't want to have. If that's happened to you, then it's important to talk about that at some point. And the patient may or may not want to go there then. I have, in doing this for a number of years and teaching how to do it, my goal is just to ask in a non-judgmental and a way that gives people permission to be honest. And the patient may or may not share. And if it's a equivocal answer or if it's a positive answer, then my kind of next step is to normalize it. This is common. We know 1 out of 4, 1 out of 3 women experience some kind of abuse in their lives, and that people don't deserve to be treated that way. No matter what you do, you don't deserve to be treated. And often it's hard for people to talk about because when they fight, sometimes they fight back and they don't want to necessarily admit that. And so part of it's, I think, normalizing and then educating that that is not a healthy relationship, that nobody deserves to be treated like that, and that there is help when somebody's ready for that. And then it's knowing what kind of help there is in your community. And as I've said, I practice in a variety of different settings. In your urban areas, you have often more resources, so it's understanding what social worker or psychologist may be skilled with intimate partner violence. Just because they have a degree doesn't mean that they are. It's important to be aware of. And in a larger setting, you may actually have a social worker in your clinic that you can, or a psychologist that can come in and talk to the patient. In a rural setting, I didn't have those kind of resources. And so I knew who my advocacy program was a half hour away. And it also happened that I had a very savvy social worker in town, and so I did a lot of referrals with her. I also was in situations where I didn't have access to a translator, and there is a domestic violence hotline where I can actually call and ask for a interpreter for a specific language, and they will interpret for a conversation with the patient related to screening for violence. And I've used that a number of times, which is very helpful, and then can help the patient figure out what is in their vicinity where they can go and get some help that will be language appropriate for them. So, we have a variety of different websites and resources that can help people do a good job with this. So there's really no reason not to.
Yeah, it sounds like there's a lot of resources that people might not know about, but it also sounds like maybe you're also advocating for, ideally, there would be some comprehensive care within the clinic or hospital-based setting. Is that right?
Yes, and in fact, the JCO and NCQA demand that. So if you're in a hospital clinic system, you need to have guidelines and protocols, and people need to get trained. And if you're in a smaller setting, that you may not have such a large scale, but there are resources out there so that you can take good care of your patients in this manner. And there's we have slides, and there are a number of resources on the slides. One of my favorite related to healthcare is the Future Without Violence. It's a nonprofit in California that's worked on this issue and has tremendous resources for patients, posters in the office, handouts, protocols, so that you really can find what you need on that website if you're trying to educate yourself or you're trying to educate a group of physicians or nurses at your clinic or whoever you may be trying to work with.
And what do those interventions look like that are successful with women that are screened positive for interpersonal violence?
So until the last 10 years, we didn't really know that. And so the U.S. Preventive Services Task Force really used to not recommend screening or not screening because we didn't really have the evidence. But in the last 10 years, we know that there's no harm that occurs with screening if we observe certain important things, and that actually does have some benefit on health. So we know that asking and then handing somebody a sheet with phone numbers is not enough. So we need to have a conversation. And that may be a conversation with someone that comes into the room, such as a social worker, or in a busy small practice, I have put the patient on the phone with the advocacy person at the domestic violence hotline a half hour away, and had them explain and speak with the patient. And it makes it much easier for the patient to follow up when they've heard a voice at that number. They have a relationship through the phone. And then the other important thing is that I bring that patient back and I follow up and see how things are going. So this is, like any other issue I'm worried about with a patient, I want to know how it's going. And it has to be a non-judgmental manner because these are complicated issues.
Yeah, so it sounds like it requires knowledge on your part of what's out there, and then also a follow-up to see how the patient is doing.
Right, which is just good care that we have with patients. If it's over the course of a pregnancy, you have many different opportunities when patients come in to see how things are going, and you also have opportunities during the follow-up, and also when the woman comes in with the baby as well.
What do you think are the biggest obstacles to get women, into the care that they need and to break this cycle of violence?
Yeah. So I think there's obstacles for the providers and there's obstacles for the patients. So for the patients, people are ashamed to talk about this. They're ashamed that they have been treated this way, they've allowed themselves to be treated this way, or they've been told that they're worthless. And so it's a very difficult issue to talk about. And patients may bring it up on their own, but usually I have found that people need to be asked and need to be given permission to talk about this. I find that a lot of times patients don't understand how this can affect their health. And so part of my job is to draw the line between hard to manage blood pressure or anxiety or depression and the stress that they're living with. And so part of my job is to help them to understand that link, and then to create an environment, a trusting environment, where we can explore what options are for them. So if people are in a really dangerous situation, leaving may be what they need to do, but that's not always the answer. For providers, it's a hard subject to talk about. However, we ask lots of personal questions about people's lives and sexuality, etc. So it really is not beyond our skill level. People are worried about time, and I think that's always an issue. If I have somebody who's in a really dangerous situation where I need to really look at what's going on, then I think about it like managing chest pain. It stops my clinic, and I deal with it. But it's not always like that. Often it's just a conversation that is shorter in the course of other issues that we're dealing with, and then I bring them in and we follow up. And so I think once providers understand how to ask, and that is not, you're in a safe relationship, right? Or do you feel safe? I think that's often too general. If I live in a inner city neighborhood, I may not feel safe. So I think you need to be more specific. Do you feel safe in your relationship, if you're going to use the safety question? So there's a variety of different screening questions out there. Some people like to begin with a more general question. I ask all my patients about their relationships because it affects their health. How do you and your partner get along? What happens when you fight? Does your partner do anything that hurts you or makes you feel afraid? So when I teach students, I always encourage them to find words that work for them. We wouldn't ask someone if they're an alcoholic, so we're not going to ask someone if they're a battered woman or an abused woman. So, they need to be appropriate questions. And then you're not going to ask a question that you don't know what to do about. And so it's important that either the clinic have that available for the provider, or the provider figures that out on their own, and get some information to have in the clinic. Sometimes simply having a poster up on the wall is enough to start a discussion with a patient.
Yeah, such thought-provoking points about the word choices that providers might make, and also, helping patients explore the health-related consequences of these things that they may not be aware of necessarily.
Right. And I think that often it's simply asking the question and allowing patients to know that there are resources and asking again. And I've had a number of patients, over the course of practice that never actually disclosed to me, but came back later after they had taken some steps to change their situation and let me know that things were better now. That I'm thinking of one patient who had headaches that we tried to work with, never really admitted an abusive relationship, but came back later and said, I'm out of that relationship, so my headaches are better.
Wow.
So I think it's, our job is really to educate and help people understand that link, as we've discussed.
So what do you think the healthcare system or systems need to have in place to support these types of interventions?
So it's important that nurses and doctors, nurse practitioners feel comfortable screening. So it may be doing some training or sending people for training. There are protocols, guidelines that you can get from the websites that we've mentioned that talk about having educational materials around the clinic, knowing who the local resources are, knowing the hotlines, knowing what therapists are educated about working with patients with intimate partner violence, knowing not to refer a couple to couples counseling, but that it has to be somebody who, if you're going to refer a couple, that the counselor knows how to manage an abusive situation. So I think that a system needs to have those pieces in place. That if you are caring for patients who don't speak English, that you have proper interpreters or access to interpreters. You don't want to use family members to translate for these kind of discussions, as you don't want family members to translate a number of other discussions. So I'm not going to have a 12-year-old translate for a pelvic exam for his mother. That's simply inappropriate.
Yeah, that's a good point about cultural competency and thinking about that in relation to this type of topic as well. Other specific resources that you think are helpful for clinicians and providers to know about?
So I'll underline the domestic violence hotline that has translation services 24 hours a day. I called it just the other week to make sure it was still operating. With this presentation, the Department of Health and Human Services has put up a website with a number of links to the various topics, including intimate partner violence. So there are also opportunities for training that are available online as well. So CDC has good stuff and also has good summaries of all the available screening tools should you decide to go that route.
So what do you think the take-home points are today? I mean, you mentioned one. Are there more things you want providers to just, know about in terms of this topic?
So I think the important thing is to ask. This is just part of good care, is to understand the lives and the homes of our patients, and if they're supportive or not. I think the next one is to help patients understand how living with abuse, living with that kind of stress affects their health, and that it may be the reason that they have headaches that we're having trouble getting under control, or it may be why we're having a hard time controlling their blood pressure, or it may be why they're having problems in the pregnancy. And so helping patients see that link and then helping them understand what they might be able to do about that. And so that's linking them with resources. So that's understanding what's available in your health system, if you're in a smaller setting in your community, who your domestic violence advocates are, if it's a program that is reputable, that you trust, who the social workers or psychologists in your community are that are willing to help patients. And then I think also setting up your clinic so you've got the supports you need. So if you need translators, kind of knowing how to do that in your clinic, knowing that there is a domestic violence hotline where you can call and get a translator, having appropriate materials, and there's just lots of great resources on the web which this program makes available on the slides. So I think bottom line is it's not that hard, it's just good care, we just need to do it.
Well, but I think you've given us a lot of very specific things to talk about and think about, and it's a really sensitive topic, but also a really important one. So I really appreciate you talking about this today.
Thank you.
Thank you.